position. Oh, or you need to check Magina lang. I actually did not study each of the special tests. But, diba, to check for the betterment of the special test, usually, if you need to move the humeral head, you need to check if it's in resting position so that you can move better, diba? Okay, if this one, binaka close back position, so, hindi ka makaano, not same with the apprehension. Yeah, this is the position, the shoulders abducted to 90 degree and externally rotated. So, mo lang muna siya. Question. With the shoulder instability, we also have here your grading. Your grade 1, this is little to no movement at all. So, grade 0, little or no movement at all. So, not that much unstable. Grade 1, your humeral head moves to the glenoid rim. Your grade 2, your humeral head rides up over the glenoid rim but spontaneously reduces, so mabalik pa siya. And then your grade 3, humeral head rides over the rim and remains dislocated. So this is the grading system of your instability. From grade 0, little to no movement. 1, humeral head moves to the glenoid rim. Grade 2, humeral head rides up over the glenoid rim but spontaneously reduces. And grade 3, humeral head rides over the rim and remains dislocated. Okay? So, this is also to check for the shoulder dislocation. You can also use this instability grading. Okay. After your shoulder instability, it might end up into your shoulder dislocation. So, this is a complete separation of your joint surfaces. From instability, a partial separation. With your shoulder dislocation, this is a complete separation of your joint surfaces. So, your humeral head and the glenoid fossa may have separate from each other. So, we also have here common direction. We have your anterior shoulder dislocation and your posterior shoulder dislocation. Same as well with the mechanism of injury, usually with the anterior, abduction and external rotation, and posterior, flexion, adduction, and internal rotation. We all can go back to your kinesiology, diba? Atong rolling kag gliding, what I've mentioned earlier. So, most common, still your anterior shoulder dislocation, it's because, what do you think? What do you think that your anterior shoulder dislocation or instability is more common?
Because of the usual movements.
If you're talking about functional, pwede. But anatomical, few supporting structures in the anterior part, especially there's no muscle to support at all. Maybe we have some few ligaments, okay pa na siya, but usually the muscles is more located posteriorly compared anteriorly, okay? And the ligaments as well, fewer. So we have here your associated injuries under your anterior shoulder dislocation. We have your axillary nerve traction, knowing that the axillary nerve comes anteriorly, no? So if there will be anterior dislocation, possible nga ma-damage si axillary nerve, leading to, if may mga past board examinations nga, the patients may experience, the patient's diagnosed with a shoulder dislocation and may experience weakness towards shoulder abduction, and what might be the cause? It should be your axillary nerve impingement or axillary nerve complication or damage. We will discuss Bankart lesion and Hill-Sachs lesions later. With your posterior instability or shoulder dislocation, there will be Bennett's lesion, reverse Bankart, and your reverse Hill-Sachs lesion. Will be discussed later under your stop lesions. So, yeah, just a picture to show the normal anatomy of your shoulder. And this is anterior dislocation, nag-move lang siya anteriorly. And your posterior dislocation, nag-move lang siya posteriorly. With the shoulder dislocation clinical manifestation, usually this is severe, sudden shoulder pain, especially this is traumatic in cause, sudden gid nga shoulder pain. Arm held in a protected position, usually in slight abduction and external rotation. Inability to mark limitation of shoulder to move, so there will be limitation of motion. Palpable displacement of the humeral head, it might be anteriorly or posteriorly, it depends on the direction, and swelling and tenderness. That's just the common clinical manifestation. Complications, as what I've mentioned, possible numbness over the lateral shoulder due to axillary nerve injury, or even weakness, no, following the motion of your deltoids. Question? Okay. Am I too fast? Japon. Okay, sige lang. Frozen shoulder. What's the other name of your frozen shoulder? It's adhesive capsulitis or your diabetic periarthritis. So this is a condition involving a thickened and contracted joint capsule that adheres to the humeral head. So it's usually more common in females and male, especially at the age of 40 to 60 years old. But more than 60 years old, both of them malevel na siya. Okay? So caused by diabetes or immobilization, no? We have your recent sprain or injury, arthritis, trauma, and the most common, which is idiopathic or unknown. And what's the most important thing to do about frozen shoulder? This is self-limiting condition. So, what does it mean?
Mahina
Mahina siya on its own. Okay? Pero medyo lawig. Following the process of the healing process of your frozen shoulder. Perfect. I think one of the self-limiting mamas daw. What makes your shoulder, your frozen shoulder unique? This is one is self-limiting. Okay? No, not compared with the other shoulder pathologies. This one makahilang siya on its own. With the clinical manifestations, there will be gradual onset of shoulder pain, but it depends on what stage. Diffuse deep aching pain around the shoulder, night pain, progressive stiffness, loss of both active and passive range of motion, difficulty with overhead reaching, or functional movements. So guys, what makes it also unique with the frozen shoulder is that both active and passive range of motions limited. Okay? Common siya with the board examination questions. That to diagnose, usually, if purely manifestations and you need to check what's the possible diagnosis, basta mention that there's loss of motion, both actively and passively, that might be to rule in your frozen shoulder or your adhesive capsulitis. Okay? With the complications, there is persistent shoulder stiffness, of course, chronic pain, especially sa stages ni frozen shoulder, marked loss of active and passive ROM, atrophy in the later stage, and functional limitations. Okay, this one, the capsular pattern. We mentioned that the shoulder joint capsular pattern first, there will be limitation of your external rotation, abduction, and internal rotation. So this will obviously apply to your frozen shoulder. The first motion to be limited or to be lost is your external rotation, followed by abduction and internal rotation. And the last motion to recover as well as your external rotation. Okay? So, special test, we have your Apley's scratch test. Yes. And then, what should you do? Compare. Okay? So, positive siya if there will be a difference of motion compared to the good side and to the bad side or to which shoulder is affected. Ano pa? Alright. So for your frozen shoulder, we have here your stages. At the first 3 months, the patient is under pre-adhesive stage. No? This is the initial phase where characterized by synovitis and inflammation of the shoulder joint. So usually there is discomfort and limitation of motion. Discomfort in a way that is painful and limitation of motion. So gastart pa lang siya. The freezing stage, usually 3 to 9 months, there is gradual development of adhesions and fibrosis within the joint capsule, and there's a stage wherein positive sa patient with most painful and nag-progress to limitation of motion. No? From stage 1, sa first 3 months, discomfort pa lang in a way that's kind of painful, and there's limitation of motion. Pagka freezing stage, 3 months to 9 months, there is already most painful or this is very painful sa patient side, at the same time progressive loss of motion, especially your external rotation, your abduction, and your internal rotation. Next, we have your frozen stage. Usually happens 9 to 15 months. In here is that there is decreased pain since na-experience yun na ang painful sa stage 2. Maybe nag-decreased pain since this is self-limiting, but there is marked limitation of motion. No, there's usually marked limitation of motion. And you can see here also the start of your muscle atrophy. Okay? This one. So with the thawing stage, occurs 15 to 24 months. This is spontaneous resolution of symptoms. No, nag-decrease ng symptoms. Maybe positive or negative pain or nag-decrease ang pain at all, but there's still a significant limitation of motion. Okay? So, I want you to remember the freezing stage. No, this is the most painful and progressive limitation of motion. The frozen stage, no, 9 to 15 months, this is the marked limitation. So, hindi na experience ang most limitation of motion, but nag-decrease ng pain. And then, with the thawing stage, which is the last stage, there will be a decreasing pain or no pain at all, but there's still a significant limitation of motion. Okay? Question? Basta common yung gagawa ng question is that here, ang most painful. What's the most painful? Freezing stage. With your labral lesions, so SLOP means your superior labrum, anterior posterior. So this is an injury to the superior labrum that may also involve the long head of the biceps tendon. Here, diba? With a Bankart lesion, this is an avulsion of the anterior inferior labrum, usually following an anterior dislocation. That's why it is associated injury kagina mentioned under your anterior dislocation. An avulsion of your anterior inferior labrum. That's your Bankart. When you reverse Bankart, of course, the opposite one. There's a tear of the posterior inferior labrum, often seen naman in posterior dislocation. Okay? With the labral lesions, labral tear, si Snyder classification, familiar? So, we have your type 1 until type 4. Type 1, this is superior labrum marked but frayed attachment of your biceps intact. So, okay, hindi na lang. Ano lang siya? With the superior labrum, frayed but intact si biceps tendon. Amo na lang na, okay? With the type 2, your superior labrum might tear at the same time, there will be affectation of your biceps tendon. Okay? Your type 3, nag-add lang sila, bakit handle tear of your labrum, but the biceps tendon still intact. So type 4, bakit handle tear of your labrum and your biceps tendon affected. Okay? So, your type 1 and your type 3, your biceps tendon, intact hindi? Intact. Your type 2 and your type 4, both of them are affected. Okay? So, sa type 1, superior labrum lang, na frayed. No? But there's still intact of your biceps tendon. Okay? Your type 2, your superior labrum, frayed, at the same time, there will be affectation of your bicep tendon. Sa type 3, bakit handle tear na gid, but the biceps tendon still intact? Your type 4, bakit handle tear of your labrum with an affectation of your biceps tendon? Clear? So 1 and 3, no, intact si biceps tendon, but affectation of your superior labrum, no? 2 and 4, both of them are affected. Okay? Mga classification, si Rockwood classification, si instability classification, si Snyder classification, it's usually common questions in your oral revalida. Okay? The long head. E di ba, dila siya gasulod? Dire, as a picture earlier. Yes. Hindi to siya man. This one, here. Ari siya. Okay? But usually, the labral lesions etiology, same naman siya gapon, fall on ito a stretched hand or your push, direct trauma of the shoulder, or even repetitive overhead activities, and degenerative changes with aging. So with the pathophysiology, a superior labrum anterior posterior lesion involves a tear of your superior glenoid labrum extending anteriorly to posterior. From the name itself, superior labrum anterior posterior. So there will be affectation of your superior glenoid labrum, yung ma-extend siya anteriorly to posteriorly. Okay? So the injury involves the attachment of your long head of the biceps tendon to the superior labrum. That's why if ma-affected si superior labrum, it might be affected as well your long head of your biceps tendon. But we still need to follow the classification mentioned kay Snyder classification earlier. Okay? If there might be an affectation of your superior long head of your biceps tendon or hindi. Okay? So with the clinical manifestation, usually this is deep, pretty localized shoulder pain, pain with overhead activities, clicking, popping, or locking sensations, and feeling of shoulder instability. The complications, of course, chronic shoulder pain, shoulder instability, and functional limitations. A special test that we can perform is your O'Brien or active compression test. Same naman ito gyapon, di ba? And your crank test. Crank test, familiar kay crank test? Yes. And then, there will be axial loading kay shoulder. If there is pain, possible, there might be affectation of your slap lesion. Here, crank means applies an axial loading, no? Axial load to your shoulder and the humerus, while there will be internally and external rotation of your shoulder. So, ano lang, axial loading. Another thing, we need to discuss your shoulder impingement syndromes. Ano yung discuss na condition? First, we have the AC joint dysfunction, followed by shoulder instability, followed by shoulder dislocation, adhesive capsulitis, ano pa? Slap, lesion, and shoulder impingement syndrome. Okay, for the shoulder impingement syndromes, we need to classify each first. Tendinitis,
Inflammation of the tendon.
of course, itis, there will be inflammation of the tendon. Tendinosis, there will be tendon degeneration. Tenosynovitis, inflammation of the synovial membrane covering the tendon. And then tenovaginitis, there will be thickening of your tendon sheath. Okay? From tendinitis to tendinosis, tenosynovitis, and your tenovaginitis. Question? Okay. Pero at least some other gapon hindi na same na may gapon nila. Pero we need to classify lang. The shoulder impingement syndromes, we have primary impairment and secondary impairment. Primary, usually this is mechanical impingement occurs because of the degenerative changes. Secondary, usually caused by other problems like muscle dynamics or other pathology. So, one is your rotator cuff tendinitis or your tendinopathy. Rotator cuff tendinitis, this is inflamed rotator cuff tendons, positive full pyrum, and limited ROM. That's why in here, kay rotator cuff tendinitis, you can differential diagnosis sino? What condition? Ano ma-differential diagnosis? Ma-DDX nyo kay ADCOP. No? What makes them different? Yes. Pag mag-discuss ka mo kay ADCOP here, no? Pwede nyo ma-mention na si rotator cuff tendinitis. no, sa under your differential diagnosis. If mag-mention ka mo later kay rotator cuff, tendinopathy, you can mention under the differential diagnosis say rotator cuff. I see adnexal capsulitis. Amula na siya. Interchange nila. Okay? So, positive full PROM. PROM siya, it's because the joint integrity, it's still okay. But my problem na siya because there's a muscle weakness. Okay? Okay? Sige. Since knowing na rotator cuff tendinopathy, muscle lang yung affected, but the joint integrity is still normal. So that's why full pa ang PROM ni patient. Maybe due to anatomical failure of your acromion or traumatic overuse, usually repetitive overhead, and degeneration through aging. And the most common under your rotator cuff tendinitis is your supraspinatus affectation due to hypervascular leading to supraspinatus tendinitis or your swimmer's shoulder. Hypovascular in a way that there is a decreased blood supply to the muscle, specifically your supraspinatus. Another classification under your impingement is your Neer's classification. Sige. Someone read and explain? Read lang. Or read lang and explain. Sige, you miss. Given naman siya sa picture. Oo.
Sige. Neer's classification. The first classification is edema plus hemorrhage. Usually occurs to people around less than 25 years old. The second classification is tendinitis or bursitis plus fibrosis, which occurs to people around 25 to 40 years old. And the third is the tendon rupture and bony spurs, which occurs to people greater than 40 years old. And the last is multi-tendon tear, which occurs also to greater than 40 years old.
You can differentiate based on the symptoms at the same time based on the age of the patient or condition or of the client or patient. Okay? So another thing to remember is your Neer's impingement classification or your Neer's classification. Special test. This is a general special test of your shoulder impingement. No? With the Hawkins-Kennedy, usually this is for supratendinitis. Your MTCAN or your jobs test, this is for supraspinatus tear. Your Neer impingement, internal rotation and fast, this is for supratendinitis as well. Your drop arm, no, this is for rotator cuff tear. And your UCOMS, this is for, wow, this is for supratendinitis. Okay? Supra. Kaya again, this is most common affectation of your shoulder impingement. Another under your shoulder impingement syndrome is your bicipital tendinopathy. Tendinopathy, this is a broader, more current term, includes any, no? It could be tendinitis, tendinosis. So this is a broader term. Let's explain it in a more specific. Bicipital tendinitis. This is an impingement, inflammation of your long head of your biceps tendon at the supraspinatus outlet or the bicipital groove. Diba? Dahil siya galabay sa bicipital groove. So, common manifestation or very visible is your pop-eye sign. This one.
Become Popeye, sir, for ruptured lang bicipital
Tendon. So this is still under your bicipital tendinitis or inflammation. So, most common injury or most common injury, we have your weightlifting, especially if they cannot able to adapt to the load, no? Ma-pop gidya si biceps, and then shoveling and the like. So, most common, ano siya gani, if may mga I think common sa board exam questions, like use strengthening of the biceps, common sa bicipital tendinitis. Since this is tendinopathy, I included POC sign because it's bicipital tendinopathy. So it may include your bicipital tendon rupture. Okay? Okay, and sa part of your discussion, ay sa part of the guidance is on bicipital tendinopathy, but that's a broader term, very general term. So, yes. Special tests, we have your slide. Familiar? May natuduan mo ka sa mga amo na eh? Okay. You know, we have your speed test, your Ludingtons, and your Yergason. Amo na eh. And then check nyo lang ang integrity if there is muscle contraction. So, especially kung which side ang wala medyo ga-contract or asymmetrical. And then si Yergason is at ER. No? Resist ka lang into. Yes. Perfect. We have your thoracic outlet syndrome, but it's not part of your upper extremity orthopedic conditions. I only included it because it's still under your shoulder impingement. So with the TUS, no, what are the structures affected? Subclavian artery, vein, and brachial plexus. Specifically what? No. The your CA to T1 or the lower. Yes, guys, taas na lang ang taas na yung iba. Hindi usually, ari naman lang diya si si TOS. So, the higher ones, mga C5, C6, usually, they're not much affected yet, okay? Yes.
C5 to T1.
Kasi diba, brachial plexus, C5 to T1. So, taas, sa mga nabing C5, so hindi na rin siya ma-affect in case of there will be supraspinatus. Supraspinatus man, so there will be TOS.
C6 po din.
So, ito gani. Bicipital tendinopathy. And lastly, we have here your calcific tendinitis. Okay. For calcific tendinitis, this is a painful condition characterized by the deposition of your calcium hydroxapatite crystals within a tendon. Usually, the most common affected tendon yapon is your supraspinatus tendon. So, it commonly affects between 30 to 60 years old and may occur with a history of trauma. No? The X-ray will help the patient diagnose with the calcific tendinitis because of the presence of your calcific deposits within the rotator cuff tendon or your specifically supraspinatus tendon if the supraspinatus is affected. Wait. Kagapitik-pitik siya sa Okay. Okay. In etiology, the exact cause is unknown still. No, this is idiopathic, but factors associated with your calcific tendinitis, as what I've mentioned, maybe it's because of degenerative changes due to age, repetitive microtrauma or injury to the patient, poor tendon vascularity. This is hypovascularity. That's why yapon most common affected is your supraspinatus. And correlated with the degenerative changes is your age, 30 to 60 years old, and then repetitive overhead activities or repetitive microtrauma. Shoulder impingement. Pwede, actually ganun guys, for the differential diagnosis, what we usually do, tanan nga shoulder conditions, tanan mo sa differential diagnosis. Knowing that the manifestation usually shoulder pain, limitation of motion. So, ano pa din ma-differential diagnosis sa shoulder? Usually sila lang yung gapon. Okay? It's just mind works na may gapon sa ila. As long as kung may makambala ka mo, kung may masulat, it's all good. Okay? Hindi na siya pa-discuss. with your calcific tendinitis, no, usually if the tendon degenerates, there will be possible occurrence of your calcium hydroxapatite crystals. So the body enters a resorption phase wherein during inflammatory cells attempts to remove the calcium, and this inflammatory response causes a severe edema, restricted motion. Over time, the calcium may fully develop in your tendon. That's why there will be calcific tendinitis in your shoulder. So from degenerative changes, no, microtrauma, there will be excessive or repetitive swelling, there might be a limitation of motion. So over time, because of these occurrences, there might be a possible development of the calcium deposits that may lead into what we call calcific tendinitis. Okay? So again, it's what I've mentioned, clinical manifestation, same, diba? Sudden or gradual onset of shoulder pain, severe pain during resorption phase, pain in localized overhead activities, limited active range of motion due to pain, and painful arc. Now, they included the painful arc. Knowing, in you perform your painful arc, 60 to 120 degrees of shoulder abduction, the affectation is your GH joint. So, yes. Complication, in the patient may experience chronic shoulder pain since ang process of your calcific tendinitis, it does not happen overnight. So, this is over time that occurs because of the degenerative changes, repetitive microtrauma, so there will be inflammations, and the development of your calcium deposits. So, chronic shoulder pain, persistent limitation of motion, and functional limitation. Same Japan. Your special test, since this is still under, no, you can perform near impingement, Hawkins kinetic test, and lastly, your painful arc. Wait lang. No, your painful arc. Sa AC joint dysfunction, you can also check patients, or you can also let the patients perform the painful arc. Okay? 170 to 180, if there's sa last 10 degrees of shoulder abduction like painful, then AC. 60 to 120. Other sources, Johnny Gamble, 45 to 120. 45 degrees to 120 or 60 to 120, your GH problem.
60 70.
For your differential diagnosis, this is according to Maggie. No, nagatag si Maggie mga differential diagnosis. For your shoulder instability versus your traumatic anterior dislocation. So you can just differentiate between. Because if instability, unstable lang, maybe there's a partial separation. Compared kay dislocation, that is complete turn or separation at all. Okay? Nothing at all. Basta amo na siya. Medyo important lang. There will be feeling of shoulder slippage, elevated and complete nagiging separation si traumatic anterior dislocation. Another thing, you can do differential diagnosis of your rotator cuff lesions or your tendinopathy, your frozen shoulder, atraumatic instability, and you might add cervical spondylosis if you want. Pero doon ka medyo layo, since i-include lang siya ni Maggie, but to be safer sa oral valid, you can just opt for rotator cuff lesions or tendinopathy, frozen shoulder, and your atraumatic instability. No? So under your rotator cuff, or adhesive capsulitis, pwede ka ni kamutang atraumatic instability.
Traumatic instability.
So explain ka lang dason. Okay? So if based with the history, usually rotator cuff 40 to 60 or 30 to 50 years old, no? Your frozen shoulder age 45 years old. So usually this one is idiopathic in nature, and atraumatic instability any age. So usually age of 10 to 35 years old, because this one, atraumatic instability is that this is not because of trauma. Maybe, ano yung reason?
Congenital.
Yes, congenital or born with the unstable joint structure.
Or dysphagia.
Cervical spondylosis at the age, it could be more than 50 years of age. So, regarding with the active movement, rotator cuff lesions, PROM is absent present. If rotator cuff lesions or tendinopathy, PROM is absent or present? Complete?
Yes.
Basta gani muscle ang affectation, usually the PROM are all complete. It's because ang gamovie is your joint, no? Is your joint structures, not the muscle. Okay? So with the rotator cuff, your joint integrity is still good, but may weakness lang of your muscle. That's why active range of motion is limited and PROM is complete or almost normal. Your rotator cuff, di ba? Cartilaginous affectation. So degenerative thickening of your capsule, it might problem with your joint integrity, at the same time, muscle weakness. So both your PROM problem and your active range of motion problem. Okay? Question, or you can add cervical spondylosis, no? Cervical spondylosis or because in here, di ba, limited ROM with pain in a way that it is usually neurological in nature. Maybe there will be impingement of a nerve which supplies the specific muscles of your shoulder, so there might be an affectation, so you can add your cervical spondylosis. Okay? Since if may impinge sa cervical, usually your C5 to T1, the brachial plexus, they are responsible for supplying the muscles. So if may impinge problem, mag-weak, possible man gyapon nga maybe you can just DDX si cervical spondylosis kay shoulder shoulder problem or pathology. Okay? Singam na siya gyapon. Okay. With your medical assessment and management, this is what I've said earlier. No, nga you can just generalize everything. Or kung gusto mo, you can specify each. Usually, diagnostic imaging, no, medical assessment. This is under medical assessment, ha? Pero guys, si medical assessment is separate din siya, guys. Medical assessment
EX.
and your medical
MX.
medical management. So dapat separate niya sila nga, diba? Kaya lain siya nga grading, lain pagid nga grading. Okay? So, with the assessment, usually mga physician's assessment, mga laboratory tests, if may laboratory, your diagnostic, since this is purely musculoskeletal, you can just put here X-ray, no? X-ray, MRI, CT scan, ultrasound. So you can just perform X-ray. This is usually the first line, no? To rule in or to rule out a possible condition, since this is less expensive and easy to perform sa X-ray. Even sa mga book reviewers, diba, makastate na dahil siya kasi patients, what's the immediate action choices sa son? X-ray, ultrasound, MRI, CT scan, none of the above. Diba? So the answer there, usually the answer, basta first line or immediate action is your X-ray. This is the easiest and less expensive. So with the X-ray, it might help you to rule in fractures, dislocations, arthritic problem, or your calcific deposits. Now, si calcific deposits, it can be diagnosed with your X-ray dyan. Okay? Your ultrasound may be your tendon pathology. Your MRI, if you want to be more specific, you can diagnose here the rotator cuff tears, labral injuries, and other soft tissue lesions. And your CT scan, it's more complex fractures or bony abnormalities. So basta mga soft, soft tissues, you can opt for MRI. If more on fractures, dislocations, you can opt for X-ray. But guys, if mag-diagnostic imaging, i-mention nyo sila isa-isa. Diba? X-ray, MRI, CT scan, and then you can usually for X-ray, Miss, Sir, you can check or assess the condition of your shoulder instability, shoulder dislocation under your X-ray. This is to rule in, to rule out. And then ma'am, sir, for MRI, you can check or to rule in your rotator cuff instability, your bicycle tendinopathy, your stop lesion, do kaamo-amo na siya. Okay? Question?
For ADCAP,
ADCAP, you can opt for MRI since soft tissues, no? Joint capsule, thickening, affectation, inflammation. So, Yes. But usually for the ad cap, it's easy naman to locate eh. Even some way na siya this one. Since easy to locate lang siya. Basta problem lang, usually at the age of 40 to 60 years old, basta mag-gets na siya if mag-experience na ka mo as PD intern for 10 months, mag-gets na sa si patient, may ad cap na siya na Like, I don't know, like maka-sense ng diagnosis ni patient. So, pero na siya. You can offer MRI. Okay? Question?
Wala po.
Perfect. So with those medical management, di ka naman sa management. Pwede ka conservative management, conservative, and your surgical. Okay? So doon ka amo lang ni siya. Butang na tanan, general. If you want to general. If you want to specific, din isa-isa ko mo ganyan sila. If general, makamba ka lang. Usually, the patient can rest or activity modification. If acute injuries, the patient can put ice, chronic, heat, NSAIDs, or analgesics for pain and inflammation. This is still medical management given to the patient, especially if they are experiencing this condition. So if may problem siya with pain, no, usually the physicians can give NSAIDs or analgesics. Immobilization, usually with the use of sling, especially if dislocation or fracture, di ba? And then, physical therapy. This is where you can correlate as well with the physical therapy, medical management, there will be PT. So, will be explained later under the PT management and PT assessment. Doon na siya, paano niya siya malusot-lusot. And patient education, obviously. With the surgical management, you can perform shoulder, arthroplasty, arthrospatic surgery, tendon repair, and your labral repair. If may problem with the slap lesion, there will be labral repair. If muscle, there will be, or tendon problem, tendon repair. If you need for this one, or this one, shoulder arthroplasty, etc., etc. Question? Okay. Last thing, we need to discuss your PT, assessment, and management. Question mark? It's because
Depends.
it depends sa inyo. Ano answer nyo? With the PT assessment, okay, let's stop that one.
Wrong.
PT
Palpitation.
management. Ano?
Eye management.
PT assessment first before you can give your special test.
Wrong.
Palpation.
OI.
OOM.
MMT.
Yes, di ba amo na siya? Perfect. Amo na wala ko na siya gisulat. It's because as a PT, kabalo ka na sa yung number mo kay patient. Okay? Pero for easier na daw ma-complete niyo siya, you just follow na lang the kung na niyo sa IE. Objective part, first, your OI, no? Palpation. Yeah, pwede pain scale, especially if the subjective part. Of course, vital signs, do ka amo na wala. Pasok gyapon na. This is objective finding man. Okay?
Mataas na dugo ko kung may sakit na baga.
ROM, MMP, especially shoulder, there might be a problem with your posture. Okay? Postural assessment. Very important, special test. Sa special test, kung gusto nyo na i-give, okay man. Sometimes, if mga mga interns, why nila gina-give everything? So that, sa side questions, may mahatag na questions. Because, with experience in oral valida, usually, ang wala gina-explain, ang muna siyang gina-side question. Or ang wala nyo na-discuss, ang muna siyang gina-side question. Like, baka lang nag-special test. Special test like for this one. So, since you mentioned the special test, what special test need to perform in that specific one? Something like that, something like that. So, doon ka muna. Okay? And, ano pa? Outcome measures. Specific outcome measures for this? SPADI, DASH, quick DASH,
Read ko,
FIM. That's FIM. If you need to be functional, you can just FIM. Gina, very general. Gina si FIM ya. If wala ka namin makita, use na lang. Pero kay may lower extremity, man siya, pero to ka, okay lang siya. Acceptable but not best. Upper extremity function test, okay, etc. etc. So,
Gita sa slide.
doon ka abo na siya. Okay? If you need to be specific, if you want, sir, ma'am, doctor inspection with the AC joint dislocation, usually makita mo displacement of the amona, like so on and so forth. Kaya na sa chichian or something. Okay? Based ang kamagapon with your symptoms or management nga mag-give nyo kay patient. With the PT management, this one depende sa inyo.
Kayo, atpacks,
No? Usually, here, may iba nga gina-generalize na lang. No? Strengthening exercise, stretching exercise, range of motion exercises. May iba nga isa-isa, no? Acute phase, ayan, return to function. For acute, usually ma'am, for acromion shoulder dysfunction, dislocation, we can give ice if there is a swelling, no? For pain, you can perform TENS.
US.
With the shoulder instability or shoulder dislocation and capsulitis, usually with acute phases, ma'am, in this condition, we can give ice, TENS, no? If chronic, when we can give hot noise pack, and etc. etc. So, if acute phases, we can just perform passive range of motion or active assisted range of motion, isometrics, strengthening, muscle set. Sino mas nag-ako? Isometric ang muscle setting, no? Ano pa? Gentle stretching,
Adjacent form.
PGM. Pwede. 1 and 2, especially if pain lang. 1 and 2 if you want to increase iron train for. Especially kay sige man, adhesive capsulitis. May specific exercise na siya napangita. Codman's or your pendulum, di ba? Tama mo ni. Guys, mag-pendulum, hindi ang shoulder ha, ang gagiwa. It's actually the trunk nga to allow lang passive motion. At least may motion to.
Basic capsulitis.
Ano pa? Sa mo na siya. Bilang side question, mali si pendulum under your adhesive capsulitis. Anong best exercise for this one? Hindi pa matapos side view. For the return to function, this is more on the vigorous, more functional overhead reaching or mga overhead activities or reaching activities, no, mga hot noise pack, if still pain, still yapon, TENS, PNF, aggressive stretching, no, intensive strengthening exercises, etc. etc. Okay? You're the PT. You're the one who can give, you're responsible of researching based on the evidence-based practices of the exercises provided by the patients. Okay? Pwede ka man kapalo sa protocols. Yes. If you want. Usually, especially if dislocation, may mga protocols, even dislocation, may mga protocols, sila yung ginadungo, may mga guidelines if ano lang ang motion. Oo, may mga pacing. And even your adhesive capsulitis, di ba? Based ka man yapon sa phase, sa grading stages nila. Question? Pwede na? With the shoulder? Shoulder pa lang ta. 44 out of 92 slides.
Ay, basic.
1 PM pa naman last, no? Oh. Break?
Gutom na siya.
10 minutes break? After elbow? Jutay lang elbow. So we're good with the shoulder.
Wala, mati-picture lang. Pwede na.
Sure, mo na erase yan.
Hindi. Okay na. Nasaan ka man PPT, sir?
Okay. Wala ko yung kamalo, kung hindi ko mag-send PPT.
Sa Teams.
Wala ko sa channel.
I-airdrop mo.
Airdrop na lang. Guys, ari pagid technique. Since kamula ni nga batch ang mga orally valida, di ba? This last week. So, pwede nyo na siya mag-group ang inyo selves. Like, sila bingadua, sila maobra note kay shoulder nga pathology, sila ni nga group, sila ni maobra note sa elbow, sila ni nga group, sila ni sa wrist and hand. Guys, in this revalida, it's not about having the high grades anymore. It's pasar dapat ang tanan. So, kung anong ginatun-an niya be, usually kung anong ginatun-an sa tanan, amo man nagyapon. So, it's better to share notes na lang. Kaya I think some of the conditions naging give is not part or are not part of the past oral valida like si calcific tendinitis. May mga napang-add nga mga conditions. So, you need to make your own gidya nga material. O pwede man yung mga pass, ipang copy-paste nyo lang to. Ang mga wala, i-add nyo lang. Like, doon ka mo na. So, like, doon ka mo na siyang tip para mas easier ka mo. Kaya you need to make a notes, you must study pa ka mo. Diba? Etc. etc. It's better na lang kung ikaw lang is individual, nga ikaw lang mo obra notes. Damo-damo niya. From definition to PT management assessment, yawan ka ni. So, as well, with the anatomy, gilid sa shoulder, you can give lang, also don't mention si brachial plexus ha. If hindi nyo gusto pag-isulat si brachial plexus, usually, gina-side question mo na siya. No, brachial plexus. So, amo lang na siya. Okay. With your elbow conditions, let's start with your lateral epicondylitis. Ang gusto ka ako, na kami nagkaroon ni lateral epicondylitis ng medial. May na-notice ka mo gina sa question? Ano tong answer?
Tennis. Ay, sa tennis naman.
Tennis? May na-answer to both something?
Wala.
Okay.
Wala ko may answer. Lagi sa line.
Sa lakadaan. Basta. So, with your lateral epicondylitis, this is an overuse tendinopathy involving your common extensor tendon. The most common affected tendon under your lateral epicondylitis is your ECRB, extensor carpi radialis brevis, followed by extensor digitorum communis, and it may include extensor carpi radialis longus. So tatlo gina sila usually. During my board examination, part of the anatomy physiology kines, your APK question, ari gid ni si lateral epicondylitis. No? One of the questions there is common extensor tendon. What is the most common tendon affected under your lateral epicondylitis? So, ang answer is your ECRB. Pero, at the very end, there's a confusion. Kay gagihambal nila, all of this kanong answer, which is, gindala nila si extensor carpi radialis brevis, extensor digitorum communis, kag extensor carpi radialis longus. Pero, if the question lang gid is most common affected, you opt for extensor carpi radialis brevis. Okay? Other name of your lateral epicondylitis is your tennis elbow. Most common mechanism of injury is your wrist extension and pronation. Special tests, si Cousins, Modlis, and si Mills. Si Cousins, patient sits with elbow flex 90 degrees. Forearm is pronated. Hand is clenched into the fist. Patient actively extends and radially deviate. And si Mills na.
Si Lolo Mills.
Si Mills is more on examiner same Japon, sit or standing, palpate ka lang lateral epicondylitis, pronate, fully flex the wrist, and then while extending the elbow, ano?
Surgery.
Ay, oo. Oo. Sige ko man. Depende man sa technique ko paano siya madumduman eh. Depende na yan guys.
Sige ko muna eh.
Sabi ko, lunong sa mga hindi ko pa maganda. And then, the very easy, si Modlis, no? Amo lang na siya. Diba? Like, pa ako ma-Modlis, ako na sa
Hindi ko na siya pag-i-ekip. Kaya para mga side view.
Para ma-side view. Epidemiology, this is usually involves the dominant arm, obviously. It's because common occupations requiring repetitive gripping, especially wrist extension, and forearm supination. Clinical manifestation, pain and tenderness over your lateral epicondyle. Pain aggravated by gripping, lifting is more unfunctional, requiring wrist extension, pain with assisted wrist extension or middle finger extension, and your decreased grip strength. Complications, same na gyapon, no? Usually complications, chronic pain or chronic lateral elbow pain, persistent weakness, and tendon degeneration, especially your common extensor tendon. At ang mga muscles mentioned earlier. Question with the lateral epicondylitis. On the other hand, your medial epicondylitis, this is an overuse tendinopathy involving your common flexor pronator tendon. So your golfer's elbow, your medial tennis elbow, or your swimmer's elbow, this is everything, aka of your medial epicondylitis. Mechanism of injury, wrist flexion and pronation. The most common affected is your pronator teres compared kay flexor carpi radialis, brevis or longus. Okay? So pronator teres, di ba apat na sila gaamo niya? So, special test, your golfer's test. So the elbow is extended, forearm is supinated, the wrist is passively extended, and fingers may also extend. This one. Like do ka, yun, something man ah. So do, here, flex, supinated, extend, and then, there will be wrist extension. In that way, do ka stretch man si flexor tendons here. Okay? So, pain and tenderness over your medial epicondyle, and symptoms are reproduced during the passive stretch of your wrist flexors. Epidemiology, medial epicondylitis is less common compared to lateral epicondylitis, which is more common. Usually affects the dominant arm, requiring for in activity, usually of golfers, baseball pitchers, throwers, and manual laborers, requiring with the use of wrist flexion and forearm pronation. Clinical manifestation, same yung yapon, but in medial epicondyle ang galing. Pain and tenderness over the medial epicondyle, pain reduces wrist flexion, and forearm pronation can decrease grip strength. Complications, same yapon, chronic, but the location lang ang nag-different with the medial elbow pain, persistent weakness since the muscles are affected, tendinosis of the common flexor tendon, and ulnar nerve irritation or entrapment. It's because medially located. Okay? Questions? This one is just a table. No? I get this from the review center. RA, review center. So, lateral epicondylitis versus medial epicondylitis. No? Due to repetitive wrist extension, si lateral. Si medial is due to repetitive wrist flexion and pronation. The special test mentions already, si Cosen, si Mills, kasi Modley, si CMM, and your medial epicondylitis test or golfer's test under your medial epicondyle. Si Global 103, this is what I've mentioned earlier. That the most common affected is the extensor carpi radialis brevis, followed by extensor dilator communis, and your ACRL. But here, the added si brachioradialis, which is, makes sense, di ba? But according sa review center, the mobile 103 composed of your ACRL, ACRD, and your brachioradialis. So, this one, a modification, this is usually common under your book reviewers. No? So, due to poor backhand stroke under your lateral epicondyle, what should you do is to use double backhand stroke, use a soft na ball, and loose and more comfortable grip. So, dapat soft ang ball para less lang force given under if mag-strike ka na. Which is dapat loose and more comfortable na grip compared sa bigger one. With your medial epicondylitis, use a looser or wider grip as well. Strike the ground with less forceful and improve your trunk rotation. Dapat if do ka mo or use ka mo with, for example, tennis, no, or mag-golf, dapat it's more on your trunk motion compared kay elbow. Okay? So, this one, ang mga modifications, gakakita na siya or common na siya gina-discuss under your book reviewers. Okay? Same, and just a picture of your lateral epicondyle and your medial epicondyle and the site where the medial epicondylitis and your lateral epicondylitis occurs. Next, we have your radial head fracture. This is a fracture of your radial head, obviously. Most common caused by push, no? Fall on an outstretched hand. This is most common elbow fracture in adult, usually associated with push injuries. Etiology, well, it's again mentioned, common siya kung push. Usually, direct blow to the elbow, axial loading through the forearm, sports injuries requiring contact sports injuries, and motor vehicular accidents. With your radial head fracture, clinical manifestations, it's the lateral elbow pain. Knowing that the radial head is located sa lateral of your elbow. There will be swelling and tenderness over the radial head, pain with forearm pronation and supination, knowing that the radial head is the one, di ba, nag-initiates or with the pronation and supination, and then your decreased elbow range of motion, especially your extension. Complications, most common, elbow stiffness, given gyapon si chronic pain, and elbow instability. In some cases, might be HO, or heterotrophic ossification, especially this is a bone involvement. I just included si pulled elbow or your nursemaid elbow since usually there is inferior subluxation of your radial head from your annular ligament. I included this one under your radial head dislocation. So the mechanism of injury usually pronated and extended na arm. Bisan amo ni siya guys, but the problem is inferior siya gyapon in a way nga go back amo with the anatomical position, di ba? Inferior ni siya gyapon. If i-push ni siya, di ba? If i-push ni siya, even though nga nakaamo ni, ang radial head will still move inferiorly. Okay? That's why inferior subluxation of your radial head. Sige, medial epicondyle, radial head dislocation, followed by olecranon bursitis. Guys. With the olecranon bursitis, we have here different names. In acute stage, you may call it as a student's elbow. If chronic stage, you may call it as Jobsman elbow or your miner's elbow. The elbow, na olecranon bursitis, as you can see, there's bursa in here. There will be inflammation of the olecranon bursa with or without a pus. So usually the signs and symptoms, the most common that you will be seeing is the goose hand appearance. Amo gini siya. Common siya sa side question. Si goose hand appearance. Don't forget this one. And limitation of your elbow motion, especially elbow flexion. Basta ganun may goose hand appearance, that is your olecranon bursitis. Etiology, repetitive trauma or prolonged pressure under your elbow, especially if student's elbow. Paano ka magsulat usually, di ba? This one. So, another cause, it's due to direct blow to the posterior elbow. Blow lang muna to the posterior elbow. Infection correlating with a septic bursitis. So there will be a fever or inflammation because of your infection and overuse activity. With the pathophysiology, repetitive irritation or trauma to the bursa causing it to inflame. So the inflamed bursa fills with excessive synovial fluid, producing a swelling over the tip of the elbow. That's why there will be a goose hand appearance or inflammation of your bursa. If bacteria in nature ang cause, in the bursa or the bacteria infection will go to the bursa, there will be septic bursitis developing, which can cause infection and more severe inflammation. That's why this is under your septic bursitis. See another nga, the last sentence mentioned here kay pathophysiology.
Goose egg, pagin niya?
Ha?
Goose egg, pagin.
Oh, pwede. Another name is a goose egg appearance. Goose egg or goose hand. Same as it.
Okay.
Or siya.
Ayan, kasi
With the clinical manifestations, Now, there is obviously visible swelling over your olecranon. There will be goose egg appearance, no? Posterior elbow pain or tenderness, warmth and erythema, especially if this is septic bursitis, no? After infection, there will be inflammation and there will be fever. That's why the is warmth and erythema. Pain with direct pressure on the posterior elbow specifically, mild limitation of elbow motion, specifically your elbow flexion, and limitation of your elbow range of motion. Complications may be chronic or recurrent bursitis, specifically of your olecranon bursa. There will be rupture of your olecranon bursa and then reduced elbow function. If we're talking about functionality of your elbow range of motion. Am I too fast?
Just right.
Just right. Another condition is your ulnar collateral ligament injury. I think this one you can do differential diagnosis kay medial epicondyle. Ulnar collateral ligament injury. No. With your ulnar collateral ligament injury, this is a sprain or tear specifically to your medial collateral ligament or your ulnar collateral ligament. Same hands lang adua. No, may be caused by excessive valgus stress or common in overhead throwing activities. So, how will you perform valgus stress?
Pasulod lang.
The question is, kung diin, sa elbow ba or sa hand? Kung sa elbow, din ka mag-put pressure.
Outside para magpasulod.
Pa?
Outside para
Result dire pa inside. How about sa hand? Pagwa. Padpaamo niho. If this one, pasulod, ari pagwa. Okay? So, but if common, maybe a common question is your hand the positioning ha? So, it's going out. But if sa elbow, it's going in. Just a trick and down of your valgus stress. Etiology, maybe it's because, again, overhead repetitive throwing activities, repetitive valgus stress, and trauma of your medial or ulnar collateral ligament. Repetitive physiology, it's because of the repetition or sudden valgus stress overloads your ulnar collateral ligaments or even micro tears. No? If mag-repetition siya, and there will be microtrauma, over time, there will be a tear or damage of your ulnar collateral ligament. Ligament.
Yes.
Sige.
So,
Clinical manifestations of your ulnar collateral ligament injury, there will be medial elbow pain. That's why you can differential diagnosis this. You can DDX it into your medial epicondylitis. Decreased throwing velocity or accuracy, feeling of elbow instability or giving way, and tenderness over your medial elbow. Specifically under your medial collateral ligament or your ulnar collateral ligament. Complications, no? Chronic medial elbow instability, and this one, ulnar nerve irritations or neuropathy, knowing that the ulnar nerve is located medially. Okay? So, the special test performed under your ulnar collateral ligament injury is first your valgus stress test. How will you perform your valgus stress test? Same ang yapon, di ba? The elbow going in, your hand going out. And your moving valgus stress test, ga-move lang. Di ba? With your moving valgus stress test here, is that patient shoulder is abducted and maximum into ER. So, while the patient is moving, or while the patient is going to ER, you're performing this one. While mag-extend siya. Okay? Normal lang guro nga, So, while maintaining the valgus force, no? Extend the elbow to approximately 30 degrees of elbow flexion. Wait, Ben. Quick siya. This is to elicit the pain, no? Under your medial side of your elbow. So, if you want a static lang siya nga test, you can opt for the valgus stress test, which is very common for the ulnar collateral ligament injury to rule in. If you want a dynamic stress, you can opt for moving valgus stress test. Na naka-shoulder abduction, ER, and then apply ka ng stress at the same time, you're quickly extending the elbow. Okay? We're done. So your elbow conditions. Apat lang sila. Your lateral epicondyle, your medial epicondylitis, lateral epicondylitis, your radial head dislocation. You come up here to include si nursemaid elbow or si pulled elbow, since there will be inferior subluxation of your humeral head, your olecranon bursitis, and your ulnar bilateral ligament sprain. So, underneath, si radial head dislocation or fracture, hindi lang sa gapon. Radial head dislocation or fracture. Then, underneath dalawa is you can opt to include si nursemaid elbow. It's because radial head ng gapon ang affectation. But inferior subluxation na niyagaling, are sa dislocation or fracture. So, here, di ba, for the differential diagnosis, you can add for the medial epicondylitis, you can DDX here see ulnar collateral ligament. Since same yapon medial elbow pain, it's just that here is the muscles affected in your UCL injury is your ligament. And then, you can also add see ulnar neuritis, which is here. No? The ulnar neuritis, since medial location, ulnar nerve is located here, medially. So, there might be a pain. And even the complications, diba, mentioned earlier, in your medial epicondylitis and your ulnar collateral ligament is affectation or impingement of your ulnar nerve. So, with your ulnar neuritis or ulnar nerve impingement, the signs and symptoms is more on neurological. Tingling sensation, no, inside middle or medial of your elbow. Pronator teres syndrome, pwede, since medially man siya gyapon ang iyang pain. You can opt anything lang, as long as you can differentiate each condition under. Sila nga duwa, pwede man sila nga duwa. Actually, kung sino, wala man mga versus sa conditions, if mag-orally valida ka mo, like the opposite, sila nga duwa, o mag-versus nyo, you can opt to differential diagnose sila duwa. No, through comparison. Sige. With your medical assessment and medical management, sige. Usually, since this is again purely musculoskeletal, you can opt now for the medical assessment of diagnostic imaging. Sino ito gyapon? Your X-ray, your MRI, your CT scan. Basta ganit mga first line for immediate or urgent test, you can opt for the X-ray. Especially if the condition is more on trauma, fracture, dislocation, or to rule out any bony abnormalities. So, for radial head dislocation, this one. Ma'am sir, if mag-orally valid ako, ma'am sir, to check for the under medical assessment of your radial head dislocation, we can opt now for X-ray, etc., etc. Also, you can check for MRI and CT scan. If again, mga soft tissues injuries, no, this one, and this one, you can opt now for your MRI. This is a more best for soft tissues, usually with your ulnar collateral ligament injuries, no, tendon injuries, for lateral epicondylitis or medial epicondylitis, and your CT scan for more complex fracture. If hindi siya ma-read in your X-ray, if it's more complex fracture or bony problem of the patient, you can opt for the CT scan. Okay? Question with the medical assessment. Okay, with the medical management, again, sino man magyapon sa elbow kagina? You can write here the conservative management and your surgical management. Conservative, no changes. Rest or activity modification. If acute or chronic, acute you can give ice, chronic you can give heat, no? Another thing, if the patients may experience pain or inflammation, your NSAIDs, even sling, diba? If here for radial head dislocation, you can opt immobilization or bracing, especially if ordered by the physician, like elbow sling or elbow splint, And of course, physical therapy and patient education. Basta gano'n mention sa physical therapy, you can opt later. With the regarding with the physical therapy, we'll explain under the physical therapy assessment and physical therapy management. Surgical management, fracture, no? We have here your fixation, open reduction, internal fixation, or you can also add their arthroplasty, specifically of your radial head. Your bursectomy under your olecranon bursitis, tendon debridement or repair under this one, lat epe and med epe, and then tendon or ligament reconstruction or repair if there's a problem with your ulnar collateral ligament injuries. So, though, di ba, pwede na siya makasunod-sunod as long as you gets na ang concepts. Okay? PT assessment, question mark. Mas safest ba, no? PT assessment and PT management. So with the PT assessment, very good na mention mo sa PT. Siyempre, kailangan mo si bicep kasi triceps, di ba? Now you can ocular inspection. Pag ocular inspection, ma'am, sir, I can say under your olecranon bursitis, there is a goose egg appearance, swelling, no? With the palpation, no, there will be tenderness, especially if there's lateral epicondylitis, lateral tenderness, no lateral epicondyle tenderness, etc. Same with the medial epicondylitis, vital signs. Pain scale, yes. You can opt for pain scale. Pwede mo ma-include si pain scale under your outcome measure, no? Numerical pain rating scale. Limb girth, pwede, especially if there's a swelling.
ULTT.
No? ULTT special test, it's more on neurological affectation na be for the radial. Pwede, ULTT 3 and 4. No, radial and ulnar.
Basta may ipit siya.
If you need to check, pwede si ULTT, especially ULTT 3 and 4. No, radial and ulnar. But, this is to rule out lang neurological problem. Pero pwede ka dito ka-add special tests. Di ba, what we have mentioned earlier, mga special tests, kay lat epi, kay mid epi, and yung ulnar collateral ligament, pwede din siya. Ma'am sir, with a special test performing the lateral epicondylitis, we can perform Mills, Modley's, Cousins test, with the medial epicondylitis, Goldfried's test, or the medial epicondylitis test. With our ulnar collateral ligament injury, we can opt to perform valgus stress test. Like to mo na siya. Ano pa? Palpation. You can also opt if you want to rule out sensory problem, sensory assessment. No? And of course, your outcome measure. Outcome measure gyapon.
Feel.
OM, SPADI, dash, quick dash or dash. Sige pa. Pwede nyo ito ma-include sa numerical pain rating scale, ha? Galing. Or si... OM na sila gyapon. Sensory. Ayun, ask ko siya sensory. This is to rule in or to rule out. This is to rule out lang. Neurological problem. Dermatomyotome, pwede. Especially the dermatomal. Kaya di ba duwa ang gina-check natin when it comes to sensory? We can follow the nerve distribution or the dermatomes. And this one, ano din si DTR. Diba? If you need to check for the upper motor neuron, lower motor neuron, especially this is more on to rule out lang nagyapon sa DTR. Kahit na mention, if you see biceps tendon, I see biceps reflex and your triceps reflex. Even the brachioradialis, so include lang for the assessment. For the PT management, you can opt for generalized lang yapon ni hambal nila mag-oral leva ka mo or gusto niyo mag-specific if atong acute or even subacute and return to function, acute, even to subacute or return to function. Same naman to gyapon guys. Basta gani acute, it's more on protective pa lang from therum or active assisted range of motion. Eyes, especially for pain and inflammation. For pain, even up for the TENS. For return to function, it's more on functionality na, no? For mga aggressive strengthening, plyometrics, overhead reaching activities, ano pa? PNF, more progressive resistant exercises, even sa akit galing ng isometrics or the muscle setting. Questions with the assessments? Kasi mga the active range of motion exercise, passive range of motion exercise. Na, di ba that's okay na siya, that's also exercise. Question? None? Okay. We're done discussing your shoulder conditions and your elbow conditions. Next, we have your forearm.